Hello, good evening, everyone. So I'm Dr. Mandurah from Saudi Arabia. I'm a subspecialized consultant in physical medicine rehabilitation, specialized in brain injury and neurorehabilitation, and currently I'm covering the stroke rehabilitation unit in King Fahd Medical City. So today we're going to talk about the principle of stroke rehabilitation care, the recommended standardized practice. And I would like to thank Tamina for inviting me to the Stroke Congress. It's my pleasure. So I have no disclosure and there's no conflict of interest. So my objectives today is about the principle of the stroke rehab care and the recommended standardized practice. And I'll get touch on the last evidence for specific therapies and treatment that eventually we'll have a bit of discussion about the technology-based intervention, including tele rehabilitation, mobile rehabilitation, and home-based rehabilitation. So as we know, the stroke is a cerebrovascular disease, is the second most common cause of mortality worldwide, while it ranks third among other causes of disability. In Saudi Arabia, with a population of more than 28 million, the stroke is one of the fastest growing cerebrovascular disease, leading to increased morbidity and mortality, thereby increasing social and economic burden in the kingdom. A recent study conducted by the Ministry of Health reported the prevalence to be 29 over 100,000 population per year. So the most powerful predictor of rehabilitation outcomes is the initial stroke severity and the age. So we divided the stroke severity according to the FIM score to mild, moderate, and severe. FIM is the function independent measurement score. So if it is scored more than 80, the patient will be landed under the outpatient rehabilitation program. If the patient FIM score was between 40 and 80, and the age is between 60, patient will be under the moderate stroke severity, and that this kind of patient will require inpatient specialized rehabilitation. However, for patients who are above than 55 with a functional independent measuring score of more than less than 40, those patients will be lying under the severe category, and those would require a specific kind of rehab, which including a caregiver support or inpatient specialized rehabilitation, or what we call it alternative level of care. So in order to measure the outcome, there is different classification system. So one of them that we spoke earlier is the FIM, which is the function independent measurement score. We also rely on motor function score. By the other hand, they call it Fugel-Meyer assessment score, ambulation and mobility, balance, speech and language, spasticity through modified Ashworth scales. We depend also on mental health, activity of daily living, the FIM, quality of life, SF36, stroke severity by modified ranking scale, and the length of stay, and eventually the mortality. So in order to go to each category, we have to know what is the modified Sackett scales and the level of the evidence of research. So when we say about level 1, we mean by that it's randomized clinical trial. And if we mean by level 2, it's randomized clinical trial with a cohort as well as prospective controlled study. When we say level 3, so it's only case control. And when we say level 4, it's either case series, and level 5 is just like observational or case report. So in terms of the rehabilitation pathway, so the patient will be initially receiving a rehabilitation in the acute care hospital or in the acute inpatient stroke, then will be transfer or discharge to the subacute inpatient stroke rehabilitation. And then ideally, it will be followed by home stroke rehabilitation, eventually outpatient stroke rehabilitation. So there's different stages And according to the severity, some patients might be only receiving rehab in the acute inpatient stroke then discharge. If it is mild, followed up by outpatient. Some patients who are between mild and moderate, they will receive some subacute inpatient. And patients who are in severe, they might receive some home stroke rehabilitation or alternative level of care. So type of a stroke recovery, there are two types, it's either neurological or functional. So the neurological, which is the spontaneous, and there is a recovery of the neurological impairment itself. And the most spontaneous recovery occurs between the 3 to 6 months post-stroke. Whereas the functional or the adaptive, which is the improving the mobility and the activity of daily living, influenced by neurological recovery, but not depending on it. And it may occur independent of neurological recovery though, and it depends on the motivation, ability to learn, family support, or the intensity and the quality of the therapy. So the neurological recovery, it's divided into early recovery and later recovery, whereas the early recovery, it's started by the erythema, which resolved into 8 weeks. And there's a perfusion of the ischemic penumbra, and including a toxic factor elimination, what we call it diastasis resolution. So later on, there is a CNS reorganization and the neuroplasticity. When we come to stroke rehabilitation, so I'm sure that we passed through a lot of definition of stroke rehabilitation, but its effective stroke rehabilitation is characterized by an interdisciplinary team working cohesively and closely to provide a comprehensive program for each patient to reduce the mortality for better functional outcome, decrease the hospital length of stay, and decrease admission, as well as fewer dependent on others at 7 months post-stroke and better quality of life. And that's including interdisciplinary team of patient himself, the family, the caregiver, attendant, physician, nursing, physiotherapy, occupational therapy, and speech language pathology, and not to forget about the psychologist, nutritionist, and eventually the social worker. So the principle of stroke rehabilitation or the standardized practice that includes stroke rehab unit, intensity of the therapy, early therapy, and task-specific training. As you see from the graph taken from the American Heart Association, it's illustrates the importance of assessing the recovery rather than the outcome when studying brain plasticity after the stroke, since depending on the individual lesion, a given outcome may correspond to different degree of plasticity. So as we see, the 3 to 6 months go what we call the golden period when receiving the rehabilitation. So timing of a stroke of rehabilitation, and what we call it a very early mobilization. So early mobilization may be beneficial for improving motor function and ambulation and mobility, but not the stroke severity or the length of the stay or mortality. So the evidence is mixed concerning the activity of daily living. Here's the AVERT trial or the article about the efficacy and the safety of very early mobilization within 24 hours of the stroke onset. The purpose of this to determine if the rehab delivered intensively within the first few days. So if very early mobilization was better, there is a multi-center of 56-site randomized controlled trial, which took 8 years to complete. They compared the patients into 1,054 versus the patient who received not a very early mobilization of 1,050. Then in phase 2, patients who went very early mobilized, they did unfortunately worse, more likely to die or have more severe stroke. So mobilization the first few days after stroke though must be carefully done. Second thing is the intensity of the therapy. Guidelines for adult stroke rehabilitation and recovery in 2016 state that a retrospective cohort study of 360 subjects demonstrated that who received more than 3 hours of therapy daily, they made significant more functional gain than who received less than 3 hours of activity daily. whereas the Canadian stroke guideline stating that the stroke rehab patient should receive a minimum of 3 hours of direct task-specific therapy, 5 days a week. So in this article, which shows the inpatient rehabilitation following the stroke, the purpose of this study to examine whether the standard was met on a single specialized stroke rehabilitation unit, and if the amount of therapy was an independent contributor to functional improvement. So 123 stroke patients were admitted to a 30-bed stroke rehabilitation program over a 6-month period. A workload measurement data were used to estimate the amount of therapy that patients received from core therapy during their inpatient stay. And they found out that the average of rehab patient gets a little or less than 2 hours of direct patient therapist time, 5 days per week. The intensity of the therapy versus the early supported discharge. So this is an observational study that including 34 stroke patients. Patient had an activity monitor worn continuously for 7 days, final week in hospital and 7 days at home. So patients at home who participate spend more time upright and walking, and they found it like they're sitting less. The depression discharge predicted greater sitting time and less upright time at home, with a p-value of less than 0.3. And they're wondering whether early discharge could be because of concern of safety, or is it like motivation? Is it cultural? So still there is an argue strongly in regard to intensity of the therapy versus the early supported discharge. In regard to the increasing the intensity, that should be included in group therapy, video games or board games, and generally have assistant apart from the major PT and the OT, and also weekend therapy is recommended. In regard to this task-specific training, so it's focused on learning or relearning a functional motor skills to optimize the function, direct toward patient's goal, and benefit to improve the grip, strength, arm and hand activity and quality of life. So there is an research made in animals to show that functional reorganization is greater for tasks which are manageable to the animal. So clinically, with the repetition of motor skills, it's play an important role including and maintaining brain changes. So repetition in the absence of the skilled motor learning is not enough though for brain reorganization to occur. So approach to the post-stroke rehabilitation, or what we call the motor recovery, it's either compensatory or restorative approach. And this is what we need to know in terms of the compensatory approach. It doesn't reduce the impairment. It just learn how to regain function or adaptive approach. And it's not sure if it is suppressed the neurological recovery. However, for the restorative approach, it maximizes the motor recovery, it maximizes the brain recovery, and that's including traditional physiotherapy, sometimes neuromuscular facilitation, some neurodevelopmental techniques like a Breaststrom, Breaststrom, stages, and task-specific, and etc. And also including the motor relearning program. For the primers and the facilitators of motor recovery, those influencing the motor pathway, we see that the approaches that excite the ipsilesional brain activity that include either task-specific activity or the constraint-induced movement therapy, CIMT, or the mirror therapy, and some pharmacological stimulant. However, some approaches for the contralesional brain activity may include the direct cranial stimulation, magnetic stimulation, and CIMT as well. For the Breaststrom approach, there are 7 stages from the flaccid to normal, with developing of the spasticity in between stage 2 and stage 5, and eventually to stage number 6, where there is no spasticity or coordination, and eventually to normal. So in BUBA training, which is one of the neurodevelopmental technique for a restorative approach. So the therapist look at the patient postural control. It looks at the movement pattern, if there's any abnormal tone, if there's any muscle weakness, then try to correct them. There's a lot of emphasis on how patients should not continue using the wrong movement pattern. However, the disadvantage is it's actually result in a slower progression in therapy. For the CIMT, or what we call the constraint-induced movement therapy, it's more popular and it does focus on immobilization of the non-paretic arm using a mitt, and then a high-intensity task-oriented training with a paretic hand. 90% of the waking hours, 6 hours a day, 5 days a week, and into a total of 2 weeks. It can be helpful for patients in the chronic stage of stroke more than 1 year. And patient must be able to extend their wrist and actively move their digit of 20-degree wrist extension and 10-degree of finger extension in at least of 2 fingers. And there is an opportunity to increase intensity of therapy at minimal cost. So motor relearning program, it's task-oriented focused on relearning of activity of daily living. So it's kind of cognitive training on muscle movement with conscious elimination of unnecessary muscle activity. And that activity includes a real life activity with the emphasis on functional training of specific tasks, such as standing, walking, and carryover of those tasks. Some studies show that the motor relearning program has significant shorter length of stay than the traditional neurodevelopmental technique program, and suggests maybe superior to conventional PT approach for achieving functional improvement. Then the mirror therapy, using the mirror so the paretic side is seen as a normal by the patient. Theory and how this works by reversing the learned paralysis of the brain. The Cochrane review they state that moderate improved movement of the affected upper and lower limb and the ability to carry out daily activity of people within and also beyond 6 months after the stroke. It also helped with the shoulder hand syndrome. What is the evidence for physical therapy post-stroke? This is a systematic review and meta-analysis done in 2014, and state that intensive, high repetitive, task-oriented and task-specific training is the best. Neurodevelopmental technique as compared to non-NDT is still equivalent. I'll just talk in brief about brain stimulation. I'm quite sure that has been discussed in the first topic in the neuromodulation or neurorehabilitation. So that include repetitive transcranial magnetic stimulation and the transcranial direct current stimulation. So it involves of a coil that produce a magnetic field that passes through the cerebral cortex, and it gives low frequency stimulation, and that inhibits the cortical excitability, while there is a high frequency stimulation increase the cortical excitability. So there is motor improvement can occur with inhibition of the unaffected hemisphere, which is inhibiting the affected side and exciting the affected hemisphere. Whereas the transcranial direct stimulation, it's mild electrical current. It's conducted through 2 surfaces, as you can see, electrode applied to the scalp, and the anodal stimulation increases the cortical excitability, whereas the cathodal stimulation decreases the cortical excitability. The literature is still mixed regarding the brain stimulation. FEES, or the functional effect stimulation, it's quite common in practice, and it's assist usually for the weak ankle dorsiflexion or the common peroneal nerve, enhancing the ankle dorsiflexion during the swing phase of the gait. Electromechanical or robotic assisted therapy also to assist or facilitate the passive range of motion and help maintain range of flexibility. So some medication for the motor recovery enhancer include fluoxetine. Fluoxetine has been tried on rat and showed that it's kind of neuroprotective action on ischemic brain. Levodopa as well as the methylphenidate. So this is a FLAME study, which was done in 2011. They have giving a fluoxetine for 5 to 10 days for stroke patient in the initial onset of the stroke within the 3 months. And they found that patients who received fluoxetine, they made better neurological recovery at 30 days. Although the mechanism is uncertain, there is a theory that it might treat the depression and or facilitate the prolonged reorganization of the brain. However, in 2019, another study called FOCUS, that published in Lancet Neurology, they studied also the effect of fluoxetine in 3,127 acute ischemic patients. And they gave them fluoxetine of 20 milligrams per day versus placebo for 6 months. And they have followed the motor recovery at 6 months. They found out there is no improvement of the disability at 6 months, and fluoxetine may lead to fracture bone and a new depression, and it has a lower incidence of depression, and patient may have on top of that bone fracture. So the conclusion about other neurostimulant levodopa, so there is level 1 evidence. There's a conflict between the use of levodopa and placebo, whereas other central nervous stimulant like the methylphenidate, level 1 again, it may produce greater improvement in the motor function than the placebo. Other technology-based intervention, what we call the Tele Rehabilitation. So the Tele Rehabilitation is particularly useful for patients who cannot access the rehabilitation center, especially after the COVID crisis. So it's a process to provide the rehabilitation service remotely through information and communication technology. This is a study that has been done in Saudi Arabia in regards to the knowledge of the physician of the telerehabilitation, how far they know about the telerehabilitation, this including a survey or questionnaire that has been distributed, and there is a total of 46% of physicians that are aware about the telerehabilitation service technology, but they haven't used it. Around 70% of those physicians, they lack of knowledge about the IT and cost. However, 52% of physicians show that it's a breach of confidentiality. Eventually, in 2020, this is a rehabilitation hospital telerehabilitation guideline in King Fahd Medical City has been released during the COVID pandemic. And worldwide, as you can see, also the Canadian Stroke Best Practice has also released their telestroke virtual healthcare implementation toolkit. Another technology that can help with receiving a rehabilitation therapy, what we call it the VIA therapy toolkit, is to enhance the clinical decision making, especially specifically for the upper limb rehabilitation after the stroke, with quality improvement initiative. So VIA therapy, you load it into a smartphone, and then that will be under the monitor of the occupational therapist. And there's the intervention will be for early phase rehab up to 12 weeks. Then after this, when the rehab may be provided in less intense manner. Another thing that has been established as a remote MOCA testing, which is the Montreal Cognitive Assessment. That's including a telephone version where they have eliminated the visual element of the mocha, and they, instead of score it like 30, the cutoff score went down to 22. And they downloaded the blind version into a website and they administered into, you can do it also over the phone. And that can be done also through an audiovisual conferences. So eventually, so we live in the period of advanced promising technologies that can improve rehabilitation of patients with a stroke in the early future. Robotic devices, brain-computer interface, non-invasive brain stimulant, and virtual reality and neuroprosthesis. Yet the shift of the rehab from hospital to home is inevitable, and we need well-evidenced model of care. Thank you so much for listening. And if there's any questions, I think I'll be the last one in this session.